So the topic of today's webinar, and this is a public webinar kind of focused on anyone that wants to better understand insomnia and what it means. I think a lot of times the concern I have from my perspective is that insomnia gets lumped as a final diagnosis and patients tend to be given medications and end case. You go into your doctor's office, you tell them you have insomnia, they give you Ambien and all right, that's a problem solved. The issue I find with that is that a lot of physicians don't actually have a proper understanding of sleep medicine because it's a relatively new field in the last couple of decades. So their comfort level in trying to figure out if you have any other sleep issues or how best to treat your sleep complaints, they don't have the expertise. And number two is a lot of physicians nowadays and even providers, whether you're nurse practitioner driven practice, is really trying to make sure that you have enough time with the patient, and a proper sleep history requires time. So as opposed to some other fields where you can kind of get a quick diagnosis pretty quickly, the insomnia history and so on is a lot more in detail and needs to be looked at. Again, this is not meant to be medical advice, but just guidance in anyone struggling with insomnia or having family members who have insomnia. So it is, definitely speak to your physician, whoever is prescribing. If you want to see us as a way to determine if you need further help, please feel free to reach out to us. Our website is sliip.com, SLIIP.com, and we'll kind of go through that in a little bit. I am a fellowship and board certified sleep and pulmonary and critical care physician. I have a telemedicine practice that's dedicated towards specialty care, which is the two fields of specialty that I can deliver effectively via telemedicine. One is pulmonary and the other one is sleep medicine. Also licensed in several states. So wherever you are, just let me know. I'd be happy to help you if any way possible. And again, if you just have questions after this, just save your questions and I'll try to answer them and best guide you so that you can then go to your physician or provider and ask them if some of this knowledge that you've gained from here may be helpful in how you are treated. So we'll kind of answer some basic questions such as what is insomnia? Beyond that, what are the consequences of insomnia? How it affects you? Do you have insomnia? So how to kind of, instead of just saying, I can't sleep well, hence I have insomnia, but really, do you actually have true a diagnosis of insomnia? And what can you do about it? So what is normal sleep? Before we kind of go into what's insomnia, it's also good for us to figure out what normal sleep is. Most of us, adult age, need about 7 to 8 hours of sleep. Most of us tend to pride ourselves with less sleep being of some forms a sign of I don't know, superior health, but honestly it's the other way around. Growing up in your teenagers, in your 20s, and you try to get away with as little sleep as possible, but you realize now, looking back, the amount of effect that it had on your performance. So getting optimal sleep is definitely something you want to get. And let's see, just want to make sure. Yeah. And so you want to make sure that you get an adequate sleep. And so 7 to 8 hours is the recommended amount of sleep for anyone in the adult age. Another misconception is that as you get older, you need less sleep. So once you hit 65, somehow or another, the amount of sleep you need is less. In actual fact, it's not that you need less sleep, is that it's harder to get good sleep because of other medical problems that come in the way. So the need for sleep is always not changing once you hit adulthood. However, the ability to get good sleep and get enough sleep is what's impacted by things that affect us as we get older. The quality of sleep in terms of how you feel when you wake up really matters on the sleep environment. Most patients have already resolved that by the time they come to a medical professional for help. Things like the temperature, the coolness, the comfort level, all of these things are the noise level as well, darkness in the room, especially if you work shift work and you end up being awake during the daytime or being asleep during the daytime. That sleep environment will affect your sleep quality. Other sleep disorders may affect your sleep quality or medical problems as well. That's what I was alluding to for patients who are older in age. Circadian factors, I think everyone knows this, especially when daylight savings time comes around and it affects us. Just even that hour change does have a significant impact on us. So circadian factors, which we'll kind of talk about a little bit more, which is the day-night variation in terms of our circadian rhythm in terms of the sleep-wake cycle, how it's impacted by the light and day, light and darkness outside of us. So we've got normal sleep. Now, what is insomnia? Insomnia is really either you have difficulty falling asleep or staying asleep. You multiple awakenings, difficult for you to finally get into sleep. You try to fall asleep, you're awake, you toss and turn. Common complaints I get is, I'm not a deep sleeper. I wake up a lot. I'm aware a lot. I have difficulty falling asleep, so I have to sit in front of a TV for hours until I finally give up and fall asleep. These are issues actually initiating sleep and also maintaining sleep. So that's what insomnia kind of gets into this bucket. But one thing I want y'all to take from here is that insomnia really is both an actual diagnosis and also a symptom. And it's always vigilant for us to ensure that we've ruled out potential causes of the insomnia before we say, yes, you have insomnia. Yes, you need this medication, or this is how you treat insomnia. Because then poorly guided therapy for a misdiagnosis may lead you to kind of be dependent on medications which you don't need, or it may cause you to ignore other problems which may have a bad effect on your health, while you think you're solving it by oh, I have a diagnosis of insomnia, hence I need trazodone or Ambien and so on. The other thing is adequate opportunity. So you need to have a good window of sleep. So you need to have 7 to 8 hours window of sleep. I mean, if you're taking care of kids or a caregiver for an elderly family member, and you don't have 7 to 8 hours of sleep, that's not insomnia. That's just insufficient sleep itself. Insomnia is that you actually have adequate amount of a window of sleep, but you can't get good quality sleep, or you keep waking up a lot, or you can't get to sleep. What drives our ability to regulate sleep, right? So one thing during this pandemic where people work from home, people are remote working, people get to stay at home and do stuff, their schedule changes because one thing is they're not exposed to as much sunlight that comes around when they get out of the house, when they commute, when they have to come back from work, when they're at work. So a lot of these things that require us to actually get exposed to adequate sunlight that sets the circadian rhythm, or this internal body clock that's triggered by light activation, is important, and we tend to miss out on that when we stay indoors mainly. The other thing is homeostasis, which is a fancy term for just really the body's ability to do something without needing kind of recuperating time. So the more active we are, the more thinking we do, the more we do during the day in terms of exercise and anything else, thinking, arguing, all of these things on your phone, checking your updates on your likes and so on Facebook and Instagram. All of these things will drive a sort of need for the body to rest. So there's accumulation. You kind of have all this junk accumulated in your brain that needs to be washed out, and sleep allows you to wash it out and restart or reset the clock from beginning. So the longer you are awake, that's what homeostasis drive is, the more likelihood you will fall asleep. Most of us have about a 16 to 18 hour window to really be awake before our body succumbs. And that's something important to always remember. When you have insomnia, you haven't actually lost the ability to fall asleep. That's something you have to take note of. You have not lost that ability. There's very few people walking on this earth presently that have lost the ability to fall asleep. And most of them, it's due to some sort of catastrophic brain injury or a massive stroke or something of that nature. But most of you all have. So don't think that, in terms of my insomnia, I'll never get this fixed. I'll never get this treated. And so homeostasis is important to go along with circadian cycle. The REM and non-REM is something beyond our scope of discussion today, but that also affects our sleep. Now, a lot of the Fitbit devices and so on, home devices will tell you or give you an idea. They're not the most accurate, but they're reasonably accurate. So what is the homeostatic drive? So that's the sleep drive here. The longer you are awake, the propensity develops, pushing you down, weighing you down, like I'm about to fall asleep. Now, as the day goes up as well, as you wake up, you get more and more awake, and you're kind of going through, and then at around 2 or 3 o'clock, you hit a little bit of a lull, generally, And so once these things come together at around 9 or 10 o'clock is when, if you're awake by, let's say at 6 or 7 o'clock in the morning, and you have a drive to stay awake for about 16 to 18 hours, by 10 o'clock at night, you're already shutting down. By midnight, you definitely are trying to get into bed. So that's how this comes together: the sleep drive, the homeostasis, the accumulation of all the junk of being active and out there and so on. But again, regarding homeostasis, if you are at home and you tend to take naps because you can now, because of remote work and your boss is not watching you, plus you're a little bit more flexible in your schedule, you will reset this. So that's why if you take naps after a certain time, you generally about after 3 or 4 o'clock in the afternoon, you tend to reset this homeostatic drive. So then by 10 or 11 o'clock at night, when you should be falling asleep again, you're not, because if you reset you allowed yourself to go to sleep, clear up all that junk that you have in your brain, and kind of start refresh again. So that's why you have inability. So nap times are important. I mean, if you really can't get through the day without a nap, it's definitely what you want to schedule that, but do it before 3 o'clock, and generally don't do it longer than 45 minutes, definitely not longer than an hour. So what sets off insomnia? Some of us just have a predisposition to it, whether we're type A personalities, whether we're just, we tend to be triggered easily. So that's a predisposing factor, which means that it's not something that we do or we are, it's just that we have a tendency, whether it's family history, whether it's medical problems and so on. Now, what's a precipitating factor? Precipitating factor is what sets it off, that moment, whether it's surgery, whether it's bearing children, whether it's a sick loved one, whether you went into the hospital and you had some sort of medical diagnosis. It's something that affected your sleep-wake cycle, something that threw you off your kilter, so to speak. Any changes in your environment, for example, that may have been enough stress in your life that caused that. Relationship issues, anything that precipitates it. Now, the perpetuating factors is what leads you then to solidify, because the precipitating factor itself and the predisposing factor doesn't really mean that you will get insomnia. It is a perpetuating factor that then locks in those behaviors and causes this to kind of repeat itself over and over again. Let me give you an example. So if you are someone who tends to fall asleep at 10 or 11 o'clock at night, but now because of exams coming up, because you've had a relationship issue, because you've had a sick family member, you tend to stay awake a little bit later at night trying to get your work done. So because you couldn't do that earlier, for whatever reason, you get into bed and you can't sleep, you can't shut your mind. Now you tend to sleep at, let's say, 2 o'clock in the morning then. Now because of that, when you wake up at your usual bedtime or wake time at 6 or 7 o'clock in the morning, you're exhausted. So what you do is you tell yourself, all right, I'm going to sleep in for a couple of hours. I'll tell the boss I'm coming in late. All right, fine. You do that. Now, what happens is you've woken up at 8 o'clock or 9 o'clock as opposed to 6 o'clock. So then we talk about the homeostatic drive. We talk about the circadian rhythm, which is that now you're awake at 9 o'clock, which means that your drive and the accumulation of your activities and so on, and being exposed to the circadian drive of being exposed to the light actually starts at 9 o'clock. So in the morning, which means that by 10 o'clock at night tonight, when you come back home, you're like, okay, I didn't get much sleep last night. I'm exhausted. I've had a lot of stress, blah, blah, blah. When you get into bed at your usual bedtime, you can't fall asleep. And this is when the perpetuating factor starts in. Oh my God, I can't sleep. Now, what happens when you're laying in bed? You can't sleep. You think. It's very hard of us. None of us are yogis or in any way Buddhist monks that can lay in bed in a state of mind that is completely serene and clear and pristine. I wish we could, but we're not. We tend to fill it in with things and thoughts and so on. And these things and thoughts tend to drive our awakening. So as opposed to being mellow and relaxed, we tend to be awake and thinking of this and thinking of that, or planning our day and trying to be more productive. And so that's where the predisposing factor is. You're just someone like, all right, I'm awake. I might as well think about this and that. Oh my God, I had an argument with him. They shouldn't have said that. What do they mean by that? And so when you get a lot of these hours that you are awake, that strengthens or perpetuates this, I can't sleep. And then finally by 11, 12 o'clock, 1 o'clock comes around and you finally fall asleep. Again, you sleep in that night. So your ability to fall asleep at 10 now has changed dramatically. You will find this on weekends, something that we call social jet lag. You're in bed by 10, awake by 6, work week, every Sundays to Fridays, right? A Sunday night, and then Friday morning you wake up. Friday night you go out, you have dinner with your friends, you have a few drinks, blah, blah, blah. It's a late night. You come back home at midnight, or you finally put your kids away to sleep, and you go to bed at midnight. Now you normally go to sleep at 10. Now you wake up on a Saturday at 8 in the morning. You do the same thing on a Saturday night. And on Sunday comes around, when you're trying to go to bed at 10, your body's been used to already being awake till 11, 12 o'clock. And so that is what causes the insomnia, or starts it, the precipitating, but it also perpetuates it. And then you're now like, damn, I can't go to sleep. This is becoming an issue. I need something to help me. And this is where the disbeliefs and so on. That's why I want to reassure you that you actually haven't lost the ability to fall asleep. And like I explained earlier, there's a difference between insufficient sleep, so you need to have adequate opportunity for sleep. What's normal now? I think we sometimes have unrealistic expectations of what is normal. It's okay to wake up a few times during the night. What's a few times? 2, 3 maximum. But really, what is not good is that your inability to fall back asleep again. You should be able to fall asleep. You wake up, you turn around, you look around, you turn back, go back to sleep. That's what normal sleep is. However, again, this goes back to the perpetuating factors. If you wake up and your first thought is, oh my God, I'm going to be awake all night. Oh my God, I'm not going to be able to fall asleep. What happens is it heightens your inability to fall asleep, because then now your heart rate goes up, you're more aware, you turn around and look at the clock, and then boom. Next thing you know, you keep thinking to yourself, oh, I haven't fallen asleep yet. I'm going to be awake. I'm going to be miserable tomorrow. I've got this meeting. I've got this deadline. I've got to take the kids out for this. I've got all these refills that I have to go to the pharmacy to get done. All these issues then start filling your head and causes that. So I want you to be aware that falling asleep is not the issue. You need to be able to fall asleep when you're awake in the middle of the night, and you shouldn't act as your own worst enemies. And we tend to think we don't sleep enough. We tend to think that, oh my God, I only slept 2 hours or 3 hours. We get this frequently. I don't sleep more than 2 hours a night. And then we'll bring them to the sleep lab. We'll put them all, we'll get them all with the sensors on their heads, the leads and so on, so we can actually monitor actual sleep. And they slept 4 or 5 hours. So I'm not saying that you don't have insomnia, but we tend to overestimate or underestimate the actual amount of sleep that we actually get. So we've covered what is insomnia. The inability to fall asleep, inability to stay asleep, right? It's not insufficient sleep. And it's also what drives it, which is homeostatic drive and your circadian drive. Homeostatic is what accumulates during the day, all the junk in your brain that needs to be cleared out. And the circadian drive, which is the external light factors that keep us somewhat, day animals in a sense. Now, what are the consequences of sleep or insomnia? Tiredness, attention, people getting more and more attention deficit disorders because of poor sleep. Memory impairment, we've found a lot of association between inadequate sleep and Alzheimer's disease or dementia later on in life, because the so-called accumulation of this junk that we have in our brains, the longer this junk stays there, they kind of coalesce together and form these little plaques that then tend to lead to issues with memory and dementia and so on. Functional status, whether you have issues at work, at school, you don't like being disturbed, you want to be alone. I mean, there are introverts and there are extroverts, and there's some people who just don't want to be disturbed all the time, and that's probably some of the consequences of poor sleep. Irritability is another one as well. So someone flying off the handle easily, getting anxious easily. So whenever think about some of these things in your own day in life. Reduced motivation, low energy levels tend to get misdiagnosed. So you go in there and you tell your doctor, my energy levels are low. So what probably will do is they'll check your thyroid level. They may check your testosterone level. They might find it lowish. So they say, well, you have a lowish level, but not truly low, and you have the symptoms. Okay, that matches. I need to fix this. And so what happens is they get misdiagnosed, and actually a lot of people get misdiagnosed and get treated with testosterone shots, or get put on hormones for low thyroid levels. And that helps them up initially, but doesn't really treat the underlying problem. So sleep may need to be addressed as well. Other consequences, people tend to self-medicate, whether prescription or non-prescription. Alcohol is probably one of the most common medications. And poor quality of life. The problem is our sleep is very personal. And it's also a passive state that we're not aware of, except when we wake up and suffer the consequences of it. So when I wake up and I'm unrefreshed, after many months or years of this happening, I'm not going to really know how I actually should be waking up or how I should feel when I wake up. That changes, and so we have nothing to compare it to. And so that's an issue with sleep, is because it's a very personal experience. So we don't really talk about it. We don't really compare it. It's like, well, a patient of mine asked me this, and it kind of struck me how stupid a question I asked. He's like, yeah, I said, do you wake up tired? And the patient looks at me, he's like, well, Dr. Bhar, it's like, how else are you supposed to wake up? And I was like, wow, he has no idea, or she has no idea what normal sleep is like. And you should wake up feeling refreshed. You should wake up feeling like I've got the energy. I can wake up. I'm just going to brush my teeth right now. I'm going to do this. Ooh, nice. Now, you may make excuses. I'm not really a morning person. Now, that may exist to some extent, but you shouldn't be dragging yourself out of bed or having to kind of always feel like you could use an extra hour or so of sleep, especially if you have adequate sleep. So that's the consequences of insomnia. We've also found there's a huge correlation between insomnia along with things like mental health issues, anxiety, depression, and so on. So that's something to take note of. We used to think this, it was like, which came first, the depression or anxiety or the insomnia, which one needs to be treated first? But now we're finding there's a bi-directional relationship, meaning that regardless of what started first, you actually need to treat both the mental health issues and the sleep to actually get things improving. So if you do one or the other, that's not going to help adequately. But what we find as well, apart from that, insomnia is also associated with other medical conditions like increased risk of high blood pressure, heart disease, dementia, and cognitive decline. So even things that may not be, and I'm not talking about dementia where you're in a nursing home and so on. I'm talking about just cognitive abilities as well. So decision-making, executive skills in terms of memory, in terms of a recall, in terms of making good decisions, in terms of quickness as well. So a lot of these things are affected by insomnia. Aging as well, and also hunger leading to obesity. So I want to show you the slide over here, which is really telling. So patients here who have between 7 to 8 hours of sleep over the span of about 15 years, their weight gain. Now we tend to gain weight a little bit more as we get older. That's not unnatural, but look at the amount that if you get 5 hours of sleep or even 9 hours of sleep and so on. So your weight gain is more compared to if you get 7 to 8 hours of sleep. And the body does that to you because of the stress. You tend to be able to eat more and not be able to keep to a diet when you get less sleep. And so this drives that obesity frequently. All right, so we talked about the consequences of insomnia, mental health issues, overall medical conditions, diabetes, high blood pressure, and so on. High blood pressure, heart disease, cognitive decline, dementia. Now, do you have insomnia? Really, and that's why you're here. Or does a loved one have insomnia? And so how do you deal with that? So insomnia evaluation, really, I mean, if you think that you have it, one of the complaints that you have is the inability to fall asleep, is the inability to stay asleep. Do you snore? Does your legs keep you awake at night? What are the questions that actually stop you, or what are the things that are stopping you from sleep? I'm assuming at this point the bedroom environment has been somewhat addressed. Your sleep scheduling, I talked about how if you sleep later one day and then you try to cheat a little bit and sleep in, how that affects your sleep-wake cycle the following day and the day after that, and how that starts as a precipitating factor and then becomes a perpetuating factor. So your sleep schedule is important. What are the consequences? So when you wake up, how do you feel when you wake up? And be honest, you shouldn't have to have a shower or have to reach for a cup of coffee to feel refreshed. You don't need stimulants during the day to feel refreshed if you're getting good quality sleep. If you're not, then you're lying to yourself and you're just kind of making excuses. The same way people make excuses, oh, I'm getting older, that's why I'm slowing down. My shortness of breath, oh, I'm getting older. Not really. So that's why I think whenever you get this diagnosis of insomnia, you may get a diagnosis of insomnia or you think you might have a diagnosis of insomnia. I just want to reiterate, just make sure that you evaluate why you have insomnia, what could be the causes, rather than just going, I have insomnia, hence I need to be treated as such. Associated impairments, like I talked about, what are your daytime consequences? Mood, school performance, job performance, energy levels, all of these things that affect us to kind of actually live our best lives. I mean, if you don't wake up feeling refreshed, you're not living your best life, then you need to start looking at sleep. We talk about, good diet. We talk about exercise or mobility, but the third real stool of good health, if you take a good health sitting on a stool with three legs, sleep, mobility, and nutrition. You need those three things to ensure that you have good health. What are your perpetuating factors? What time are you getting into bed? Are you getting into bed when you're tired? Or are you getting into bed because that's the time that you socially thought that you should get into bed? Are you getting into bed because that's the time your bed partner wants to get into bed? Are you getting into bed now because you feel sleepy enough that needs to be? Now, when you get into bed, why is your mind racing? Is it because you're not able to fall asleep, hence your mind is racing, or is it the other way around? A lot of times we will blame the racing mind. In actual fact, the mind is always filled with thoughts. When it's sleepy enough, those thoughts will fade away. The only problem is that if you're also laying down and you're not ready for sleep yet, you will then perpetuate these racing thoughts, and the thoughts will keep increasing your anxiety level and actually not allowing you to fall asleep. So the timing of sleep really is important. I'll talk about how to deal with this a little bit. Environmental factors, like I said, you probably should have already addressed that. Coolness in the room, darkness in the room, quietness in the room, comfort level. Medications is somewhat always ignored because of the number of times that we are given different kinds of medications. They may interact and actually cause you to not able to be not may interact to cause you issues related to sleep itself. What are the issues that you have? Could insomnia be driven? Like I said, insomnia sometimes is a symptom. A lot of times I find insomnia is a symptom. What drives that? Is there other sleep disorders masquerading as insomnia? Is psychiatric illness or mental health issues causing insomnia? Is pain causing insomnia? Do you have other medical problems like COPD, emphysema, poorly controlled asthma, diabetes, all these things that drive this sort of I can't sleep or I feel low energy and so on. So it has to be looked at in a very holistic manner so that we actually address the underlying problem that leads to insomnia. Because you don't want to just jump to the conclusion, I have insomnia, I'm on Ambien, problem solved. That is the last thing you should take from this talk today. What are the comorbid sleep disorders? So I spoke about insomnia and things that may masquerade as insomnia. Let me give you an example here with obstructive sleep apnea. Most men that come in and have obstructive sleep apnea, and obstructive sleep apnea is when you snore loudly and you stop breathing or don't breathe well at night. Now, most men will complain, well, most men will not complain, their spouses will complain that they snore loudly. They also have daytime sleepiness, and so, or they stop breathing. So it's a very dramatic sort of presentation. And most of them are dragged in, not really excited about the fact that they have to be evaluated. But what is interesting is that in women, when you have sleep apnea, most women will complain not of sleepiness, but they will complain of insomnia. I can't sleep. I can't stay asleep. I don't wake up feeling refreshed. All of these symptoms, which very much are consistent with insomnia, I see a lot of women, especially because then they also tend to have their presentation for the sleep apnea also occurs when in their menopausal years and thereafter, because once they hit menopause and they lose the estrogen, their musculature also weakens, the muscles of the airway as well weaken, which then leads to apneic episodes where your airway collapses, right? But most of them will complain of hot flashes or insomnia, I can't stay asleep, be given Ambien. Now what Ambien does, or any of the benzodiazepine or non-benzos, will just kind of suppress your awareness. So what it does is it just drugs you up. And don't get me wrong, I'm not trying to say that you shouldn't use these medications. I'm just trying to say all it does is it kind of smooths over the cracks, but doesn't really solve the problem that led to the crack itself. So you have to really see whether some of these issues that are driving your diagnosis of insomnia, that are driving the need for medications to treat your insomnia, is it truly insomnia, or could it be a secondary sleep issue that's masquerading as as insomnia? Restless legs is another one as well. It doesn't frequently gets overlooked because most physicians, most primary care doctors, most primary care nurse practitioners have not really been adequately trained in the sleep field. So they don't ask these questions unless, of course, it becomes severe enough that the patient brings it up themselves. And even then, how you treat it is very different. So again, your inability to fall asleep is insomnia itself. Yes, you may have that, but what is causing it? Maybe various things. Caffeine, does caffeine affect? Yes, but caffeine affects you differently as you age, different medications you take. If you're going through pregnancy, all of these things are affected by, will affect will affect the timeline. So let's say you're younger and you're like, I can drink coffee at 6 in the evening or 8 in the evening and still go to bed by 10 o'clock. As you get older, or if you're on medications, or if you're pregnant, it changes. So be aware of that. Some things will change in life, and caffeine's effect on you will. Nicotine. Now, nicotine is something that affects patients both ways. It sometimes acts as a stimulant. So I'd be cautious if you have difficulty falling asleep and you're smoking very close to bedtime, consider that as a possibility. Now, what I find is at times I can't tell you to go cold turkey, because if I tell you stop smoking completely before you go to bed, it might also be a relaxant for you as well. So though the official line is nicotine is bad for you, and definitely I don't want you to smoke, but telling you to go cold turkey right before bedtime may not be the best advice as well. So it is really depending. If you're smoking a lot before bedtime, I definitely encourage you to cut down on the amount you smoke to see whether that actually has a positive effect on your sleep. And if it does, then you know it is the nicotine that's driving your inability to fall asleep. Some people will wake up in the middle of the night and feel like they need a smoke. So again, look and see whether that's a cause of it. Because if you wake up and you're anxious about falling asleep again, then nicotine might help. But the problem is, it's why are you waking up anxious that you can't fall back asleep again? Because you, like I said in the first slide, no one has really lost their ability to fall asleep. Sorry, whoever's on, can you mute yourself so we don't actually have to hear the background music? Thank you. All right, and so eating as well. Most people think, well, maybe I need a nice full meal so I can fall asleep. Not really a good idea, because it does, if you eat something in high calories, it's going to slow down your gut transit. It's going to make you feel bloated as well. Plus, you may have reflux as well from that. But if you want something, let's say you're someone who's good with the diet and you eat at 6 o'clock in the evening, and around 9 or 10 o'clock before bedtime, you get a little hungry and you don't want to be hungry in bed. You want to make sure that you have something that's high in protein. You know, a good snack would be something like crackers and along with peanut butter. That's very high in protein and will help you significantly as well without having the issue of having reflux and so on. Exercise and sleep. I don't want to tell you not to exercise, but if you're exercising right before bedtime and you have the difficulty falling asleep, I'd say reconsider the timing of your exercise, but I definitely will encourage exercise. It kind of goes along with the homeostatic drive, which is the drive, the accumulation, all the exercise, the activity, the tiredness that you feel, the accumulation of all these sort of byproducts of highly active, highly charged days will actually improve your ability to fall asleep. At times, some people who do this right before bedtime, because that's the only time they can do this, when their family members have finally gotten to sleep and they're not being bugged anymore. Honestly, that's not me. But anyways, it's also a cause. It may be a cause if it's too close to bedtime. So I think early evening might be a good time, but anywhere close to bedtime. Now, if you don't have any sleep problems and you're exercising half an hour before you go to bed, whether you're doing sit-ups or whether you're doing whatever you're doing, getting on your Peloton, if you do that, you shower and you're able to hit the pillow and fall asleep, then don't worry about what I said, then you don't have an issue. But if you are having an issue falling asleep or staying asleep, then think about the effect of exercise. I definitely want you to exercise because I think that allows you to fall asleep, but too close to bedtime. All right, what can you do? And I know we were supposed to do the Q&A after, but we started a little bit late. So what I want to do is kind of go over what you can do to address your insomnia issues. And then we'll wrap things up and we'll open up the questions for any issues that y'all may have, any questions that y'all may have. So how do you treat at home? How do you avoid having to see a doctor? Which is a good thing. You want to stay away from seeing doctors, especially if you have mild issues. Is to actually, the two things you want to look at is stimulus control and sleep restriction, which we'll go to a little in deeper detail after this. But you want to, what I spoke about the bedtime and the sleep-wake cycle is you really want to wake up at the same time every day. So the getting up is really important, because once you set that flag or you set that marker in your data, in your sleep, once you're awake at that point, the homeostatic drive starts, meaning that the junk starts accumulating. You're active, you're doing this, you're feeding your kids. And then also you're outside, you're exposed to sunlight. And all of these things sets the circadian clock or circadian rhythm as well running. So waking up at the same time is extremely important. Most people try to force themselves to sleep, which never really happens in a good way or never ends well, because you can't really, you're falling asleep, you're not forcing yourself asleep. So the falling asleep part will really come naturally once you're able to wake up at every day. So that meaning that if today, for example, was a day that you didn't get good sleep for whatever reason, either something bothered you, you had work and so on, but you cannot cheat and lie in for an extra 2 hours or an hour and so on, unless of course you feel like that's going to affect your day significantly. I'm not telling you to wake up and feel miserable, because it will cause you to feel tired, and I don't want you driving after that either. But I want you to understand some of the actions that you take in terms of sleeping in does have an impact for you to fall asleep again after that. And don't go to sleep or don't get into bed unless you really are sleepy. So unless you're ready to hit the pillow and fall asleep. So even if your spouse sleeps earlier, you may choose to sleep a little bit later, because the inability to fall asleep starts with you thinking about, maybe I can't fall asleep. It's always half an hour for me to fall asleep. Generally takes you anywhere between a few minutes to up to 20 minutes, no more than that, to fall asleep. So if you're going to sleep too early, you're going to be awake for a long period of time in bed with the idea of this bracing thoughts that keep filling your head, because now you're more anxious and you're 25 minutes in and you're like, why can't I sleep? I really need it tomorrow. I have this and that and 500 things to do. And that's what drives a lot of the awakening and keeps you awake rather than letting you fall asleep. And if you can't fall asleep, get up and do something relaxing. Go to a place that's dimly lit, and so that helps. So I mentioned two things to help you. One is stimulus control and sleep restriction. So what truly is stimulus control is to maintain the sleep-wake cycle. So making sure that you set the wake time. The wake time may be determined on what you feel is comfortable. Like, I need to get up by a certain time because I want to exercise, or I have to do this for my kids, and so on. And keep the bedroom and your bed for certain things, sleep and sex generally. And I say this, I know people have TVs in bed, and I fought this for a really long time to have a TV in bed because my wife does suffer from some insomnia at times. But if you don't have any problems falling asleep and staying asleep, then it's okay to do other things in bed as well, like watching TV. But if you're someone with insomnia and difficulty falling asleep and staying asleep, then having a TV in bed is really not a good idea. The way I would describe it is, if you have diabetes, I would say try to avoid having the whole cake, a little bit of the cake. And you're like, why can't I have the whole cake? Well, you have diabetes. So why can a friend of mine have the cake? Well, they can because they don't have diabetes. So if you have insomnia, you have consequences of this poor relationship between bed and sleep, then you need to be a lot stricter about it. So that's how I kind of describe that. Avoid napping, because again, napping resets the homeostatic drive. So make sure that you don't take naps during the day, especially. Now, sometimes that's also another way that you cheat, and then you can't fall asleep again. Now, because if you take a nap late when you come back from work, you're like, I need a nap right now. What that does is it then resets your homeostatic drive, and then you're not able to fall asleep at 10, which you really wanted to. Now you sleep at 11:30 and 12, and you only get about 6 hours of sleep by the time you wake up at 6 o'clock every morning. So that perpetuates that behavior, this sort of changes that you take, and you slowly, these are changes you did to adapt, but these are changes that cause your issues with insomnia to persist. Sleep restriction, which is basically trying to keep your time in bed to the minimum, meaning that you get into bed only when you're really sleepy. Now, sometimes when you're trying to alter your rhythm here, and you're trying to say, you know what, I'm going to wake up at the same time every day because I'm having this insomnia issue, but I don't want my wake time to vary, which affects my sleep time. When you plant that flag and say you want to wake up at 6 o'clock or 6:30 or 7 or 7:30, whatever it is that suits your lifestyle, you will realize that the first few days you may get inadequate sleep. And so I want you to be aware of that, so that you're not operating heavy machinery or putting your life at risk. And generally you may want to start this on a Friday or so on, like a weekend, so that you have a few days to kind of get over the first few days of where you are a little sleep deprived, because you're trying to consolidate your sleep. You're trying to get your sleep in a more consolidated manner, so you can get your REM sleep and non-REM sleep as you should. Now, a good way to kind of look at that as well as or visualize your sleep habits is just sleep diary. Now, this is an old school sleep diary. Most of y'all probably have Fitbits now that will kind of draw this out and map this out for y'all. But it's helpful as well because you can kind of see that variation in sleep, okay? Sleep and wake times that occur, especially in this patient here. They've been really good at waking up around the same time, but you can see the variation of sleep. And at times I've seen this where, it's 11, 11, 11, 11, 11. And the last Saturday and Sundays, Fridays and Saturdays is like 2 o'clock in the morning, 1 o'clock in the morning. And then Sundays are a horrible day. So they end up staying awake in bed. So sleep diaries are good because it helps you visualize, and actually you might be able to solve your own problems without needing medical advice. I couldn't resist putting this picture in, and it's definitely not what I meant by relaxation therapy to help you sleep with insomnia, though I think it's a great way to relax. Progressive muscle relaxation. Now, this is when you get into bed and you're trying to get to sleep, but you have all these factors like your brain's racing or your mind's racing, and you have these thoughts that you can't fall asleep. You need to break that. So deep breathing is what I personally use. And the way I think of it is we talked about like counting sheep and so on. I can't count when I'm trying to fall asleep. I tend to lose track of that, and that frustrates me. So I just focus on taking deep breaths each time. One deep breath in, one deep breath out, deep breath in, and expect your mind to wander. Don't get frustrated when your mind wanders. Just bring it back to just go, oops. And that's what I do. I'm deep breathing, closing my eyes. I'm just focusing, taking slow deep breaths in and out. You can do abdominal breathing, regular breathing, but I find deep breathing the best because the deep breath itself causes vagus nerve stimulation, which then relaxes you. So you deep breathe and then your mind will go away or go off in tangent somewhere else. You bring it back and you focus on your breathing in. Goes away again. Come bring it back. Keep breathing. Goes away again. You do this over and over and over again until you just focus on your breathing eventually, and then you will drift off asleep. Progressive muscle relaxation is this it's a little cool tool. I don't use it very much. But what it does, it's actually pretty nice. You start in your toes and you crunch your toes, and then you relax your toes, and you crunch your ankle, and you tense your ankle area up, and then you do your calf muscles, you tense it up and then you relax it, and then your quadriceps, you tense it and then you relax, your abdominal muscles, tense and relax, your shoulder muscles, tense and relax, and your fingers, you tense and relax. And so you do that over and over again until you reach your brain, and you go all the way down again. So it just is a way to kind of take your mind off the fact that, well, it distracts you just long enough, but it also relaxes you. Sleep hygiene, we've gone through this before, but I'm assuming there's something that you should think about as well. What may set off some of these issues. Clock watching is a big one. There's no reason for you to look at the clock when you have insomnia, because that actually heightens your anxiety. Now, medications. I suggest medications if you have short-term insomnia and insomnia related to some sort of stressor that you can clearly identify. But if you need medications persistently, meaning more than 2 to 3 months to help you sleep, then you should figure out what else is going on and maybe seek professional help, because you don't want to be dependent on sleep. Now, not so much dependence as well. You actually get dependence on the drugs. And some of these drugs actually they don't actually have innate dependence, meaning that it doesn't change your brain chemicals in any way. It's just more of a psychological dependence. And so the question is, you can start the medications, that's fine, but always have a thought or a plan to stop the medications eventually. One way to stop is to cut it down a little bit so you don't go cold turkey. Because even though you don't have a physiological, which means a brain chemical imbalance because of using this, and you feel like you have to use it, it's more the psychological withdrawal effect. So like if you take Ambien and you stop it, there is known to have some sort of rebound insomnia from that. So if you're going to cut down on these medications, you may want to cut down the dose first, and expect certain nights that you don't take it. It won't be the greatest sleep in the world, but you will get there eventually, because you just have to kind of wean yourself off it. Now, that being said, if you're on medications long-term, you definitely want to figure out if insomnia truly is the diagnosis, or is it something else masquerading as insomnia? All right. Non-prescription medications, we do this all the time. There's pharmacies filled with this. And that's why it doesn't work, because if there was, there'll just be one medication that works, and that's, there'll be like the sleep medication, the sleep medication. But there's many different variations, because some of them work, some of them don't. But generally for short-term use, I can't tell you not to use it, especially if you have a known factor that's causing you not to be able to sleep, whether it's daylight savings time or you work a night shift here and there and so on. Alcohol is probably the most abused non-prescription. I wonder whether that could ever be prescribed. But yes, non-prescription medication that's often used to help us fall asleep or masks some of our inability to fall asleep. Now, what it does, alcohol does, is actually help us fall asleep, but then it causes us to fragment our sleep. So our sleep is never refreshing. Natural remedies. I don't know whether turmeric really works, but most of the time you'll use things like melatonin and so on. Melatonin does work for some patients, doesn't work for everyone. The issue really is it's not FDA regulated. So what you're buying on the counter or on Amazon, just make sure you're checking the contents. Just make sure it's a certified and reputable seller as well, because the content or the dosage of melatonin can differ significantly. Just because it says melatonin on it doesn't mean there's enough to help you fall asleep. The other options are there, like valerian root and so on, chamomile tea, whatever floats your boat. That is my personal opinion. If you find it works for you, great, go with that. If you have a certain sleep routine at night to help you fall asleep, go with that. If your sleep routine becomes very complicated and requires you to be so exhausted before you fall asleep, then you may need to get evaluated by a medical professional. But if it requires something easy that you can get access to, and if you're in Georgia, then I guess cannabis may not be the best thing for you or legally, but if you're in other states, that might help you. Again, there's always side effects related to that. So that's about it. We covered what is insomnia, whether you have insomnia, whether it's something else masquerading as insomnia, the consequences of insomnia and on your risk of dementia or cognitive abilities, heart disease, high blood pressure, mental health. So all these consequences and what you can do about it. So the two things are stimulus control and restriction. So stimulus control, meaning that you just have the same sleep-wake cycle, starting off with at least waking up at the same time every day, going to bed only when you're sleepy, and trying to get out of bed if you're unable to fall asleep. And understanding full well that all these things, that if you do have insomnia, you haven't actually lost the ability to fall asleep. You'll get back on that horse again. All right. And what you can do, we discussed that as well. So yeah, I think this is a good summary here. It might be a diagnosis or a disorder itself, or it may be a symptom. It can impact your mental health and your physical well-being. And the strategies I primarily do is to make sure that I'm not missing out on another secondary cause or a treatable cause. Even looking at your medication list to see there's a medication that might be causing you to be feeling like you can't stay asleep. Looking at all of that, trying to figure out if your sleep-wake cycle is appropriate, making sure that there's nothing else that's causing you to inability to fall asleep, like sleep apnea or restless legs, other medical conditions, pain issues, and so on. And then, of course, if you do end up having a diagnosis of insomnia, the best way to treat it, like I said, is stimulus control and restriction, sleep restriction. And if you need medications for short-term use, it's fine, but eventually you should try to get off it. All right. So these are my resources. So this is my resource. I can open it up now. Oops. 2 questions. If anyone has any questions right now. If any one of you all needs any help in terms of an evaluation, please feel free as well to look up our website, which is sliiip.com, sliiip.com. We have patient resources there as well. We do these talks. This talk, for example, will be recorded and be available for anyone that needs it, and to view and to share and so on. So feel free to do that. If you don't have any need to ask me a question now, you can always come back and review this or share this with anyone else that you feel may benefit from this. But the most important thing I think I want to kind of just clarify is that if you feel like you have insomnia, make sure that your provider does their due diligence before just diagnosing you with it and treating you with the medication. Make sure that you ask the right questions, and hopefully this talk has allowed you to ask the right questions so that you don't feel like you're just being treated with a medication that may make you dependent on it without really treating the underlying cause. Thank you, Lindsay.
Dr. Avi, I just have a quick question for you.
Sure.
If you, like, I'm just doing sleep coaching. I've done the sleep coach course with Nick Lamb.
Nice.
I'm just starting to do some sleep coaching myself. What if you recognize that someone does have that chronic long-term insomnia and you feel like cognitive behavioral therapy is maybe the way to go after you've tried some other interventions, you've ruled out, the typical sleep disorders and OSA, who's the best practitioners that you can refer that person to get that help?
So good question. Thank you for that question, Jennifer. The CBTI really is cognitive behavioral therapy for insomnia is a specialized skill set. And I think sleep coaches have some training in that, which is great. What I tend to do in my practice, since we are a telemedicine practice, is that we prescribe CBTI. We work with a few online providers, and these online providers are actually FDA approved to provide CBTI online. So they've done studies to mimic what they're doing in terms of inpatient, in-person care with a therapy program that can be delivered online, whether it's through watching videos along with some of these monitoring of how your sleep-wake cycle is and writing it down in an app. So we work with a few of them. There's one of them we work with specifically that we refer our patients to. So most of our CBTI is done online as well, which gels with what we do as a telemedicine practice online. So we don't use any specific practitioners in a local area because, like I said, since we're telemedicine, we're covering several states. It's not scalable for us. But if you have someone locally that can work with you on that, that's great. But we tend to work with online providers who are FDA approved to deliver CBTI to patients.
Perfect. Thank you.
No problem. Thanks, Trideep. Anyone else? Any questions? If y'all not, then I will go ahead and end this webinar today. And y'all should receive a video after this of the recording, and feel free to share it. If y'all have any questions, email us info@Sliiip, or give us a call if you have a patient to refer. Or otherwise, if you just need patient resources, go to sliiip.com, look under the tab resources. We have videos there that talk through sleep issues, the videos on pulmonary issues as well, since I'm a pulmonary doctor. All right, ladies and gentlemen, thank you very much and have a good weekend.